good evening from here and good morning to you, Dr. Nasha Winters. Yeah,
Thank you. Great to be here.
thank you. So I'll just start with a little bit of brief introduction. We welcome everyone to India's second Metabolic Health Conference. My name is Harshil Suvarnakar. I'm a
Wonderful.
metabolic health coach and bioenergetics researcher and a member of DLife.in, which is India's oldest, biggest, and the only award-winning low-carb platform. Shashikant the Younger and Anup Singh bring to you this historic and scientific feast from India titled Metabolic Therapies. Now, with great pleasure that I would want to introduce to you our distinguished speaker for today, Dr. Nasha Winters. She is a global healthcare authority and best-selling author in integrative cancer care and research consulting with physicians around the world. She has educated hundreds of professionals in the clinical use of mistletoe and has created robust educational programs for both healthcare institutions and the public on incorporating vetted integrative therapies in cancer care to enhance outcomes. Dr. Winters is currently focused on opening a comprehensive metabolic oncology hospital and research institute in the US, where the best standard of care has to offer and the most advanced integrative therapies will be offered. The facility will be in a residential setting on a gorgeous campus against the backdrop of regenerative farming, EMF mitigation, and retreat, as well as state-of-the-art medical technology and data collection and evaluation to improve the patient outcomes who are logged in there. So welcome, Dr. Nasha Winters, and thank you for taking time out of your busy schedule and joining us.
Thank you. This is
To start,
absolutely my pleasure.
yeah. So to start with, can you please provide us an overview of what the metabolic approach to cancer entails and how is it different from conventional cancer treatments?
Sure. And I understand that you all had the distinct pleasure of learning from Dr. Thomas Seafried yesterday. So
Yes.
I know that you probably have a little bit of foundation to this, so I won't delve deep into the biochemistry. I'll bring more of the clinical description to the room here. But basically, most people know at this point that the metabolic approach to cancer is also a theory, as is the somatic mutation theory, which we've been using since 1914 when Theodore Boveri brought that to our attention, which is how we have set up our entire focus in the oncology space, that we think that the gene is the problem, and therefore we look for the single target with the single treatment. And we've been playing in this experiment for well over 100 years. And even more so, we've doubled down since the 1970s into this arena. And even after we mapped the genome, we thought, this is going to be it. This is where the answer will be. And yet it still wasn't. And so what was nice is Dr. Seafried and others kind of dusted off another theory that was emerging around the same time as Dr. Boveri's in the early 1900s, which was that of Otto Warburg, who started to understand that maybe there was something upstream from the genetic issues, which was really honed in the metabolic mitochondrial space, which is this change in the tumor microenvironment, and specifically change in a shift in the energy metabolism of the cell and we've now learned nutrient sensing and signaling changes. All of these things seem to kind of trump the gene, that basically if something goes awry at the mitochondrial level, it makes for a more vulnerable genome. And so that's one way that we're starting to understand this. And the way we've been approaching cancer, as I said before, has been a little bit missing the mark, if you will. And so bringing in and resurrecting these metabolic approaches has been really amazing. There's been a lot of researchers around the globe. There's been a lot of clinicians applying it. And even though the field of metabolic oncology is very new, there's also not a standard of care. There's not a best practices out there. But I will share what I do in practice and what I train clinicians to is we take a very much of a test, assess, address, don't guess approach, meaning that just because you assume that there are certain changes in the body happening, we can actually test for these changes today. We can really know very specifically which metabolic shift that patient has made. Are they simply just, is insulin the main problem? Is that what we need to focus on? Or are there other things such as glutamine or arginine or lysine, right, or excuse me, not lysine, cysteine, or some of these other amino acids at play? Or are there even internal fatty acid oxidation processes? So basically, you can see a variety of metabolic shifts when a cancer takes root. And instead of guessing and trying to hit everything at once, we can really define what those targets are within our patients and give them a truly personalized experience. And so in that, we use food as the foundation, or lack of food, if you will, as the foundation. So caloric restriction, intermittent fasting, therapeutic ketogenic diet, which is the high fat, low carb. We can even just use carb restriction, and we can even use exogenous ketones and even some pharmaceuticals to achieve a state of ketosis, which is a physiological state, not a diet per se. And that physiologic state creates an extra pressure in the system that makes the cancer cells more vulnerable to whatever therapies we bring on board. And so it's not even to say that the metabolic approach throws the standard of care approach out. It's that we actually see very, very clearly in our practices and in the research that when we bring on a metabolic approach with this fundamental addressing those metabolic changes, when we bring in that extra pressure, whatever standard of care therapies, chemo, radiation, targeted therapies, PARP inhibitors, other hormone endocrine therapies, seem to work better. The patient reserves a response to that for much longer, so they don't develop the resistance as long. They have much better support of the side effects, and they really do seem to have a synergistic effect that makes for a much quicker end point to tumor regression. So those are just some things I think are really exciting, that this is still a very burdening, evolving and emerging field. And I think that one of the goals I have, and people like Thomas Seyfried, when we're one guy at the bench and one at the bedside, is we do want to really create some of those, I guess, standards or some of those ways to approach this, because there are many, many ways to achieve metabolic flexibility in the cancer space. And we want to just see what is actually working the best.
Right. That's great. So it's like, having a partnership with the standard of care treatment, where with us in partnership, maybe in metabolic therapies, the standard of care treatment works much, much better than what it would have worked otherwise.
Absolutely. So it doesn't have to be a polarity. It doesn't have to be a battle between. It's like, how can we bring these together? Because we probably won't be getting rid of standard of care anytime soon. So how can we enhance it? How can we make the patient's experience with it much better? And I believe that this is a tool that does that. And I want to say that I've also worked with plenty of patients over my career that we simply used a metabolic approach without the standard of care and had some pretty impressive outcomes as well. So there's a lot of room for growth and knowledge here.
Yeah. So just strip the cancer cells of its armor and then attack it,
Nailed it. Yeah.
So maybe can you just what led you to focus on the metabolic aspects of cancer in your research and clinical practice? And,
sure.
So if you can just give us some view on that.
Sure. Well, I should probably start with the fact that this kind of ties a few conversations in at once, but I started in this journey on my own. Over 32 years ago, I was diagnosed with terminal ovarian cancer, given just a few months to live. And there were no opportunities. Standard of care couldn't offer anything. My organs were in failure. I had a bowel blockage. I was too sick to even take a single dose of chemotherapy. And so I was basically sent home to die. And that was, I didn't expect to live. That wasn't the thing. I wasn't like, I'm going to go out and fight this and figure it out. I was frankly too weak, too poor, too broken down to even consider these options. But what I did have, which was a total accident, was I had this bowel blockage, which didn't allow me to eat. I couldn't eat for 2.5 months. And so even in the first bit, even small amounts of liquids caused excruciating pain or caused me to throw up. And that was not fun, as you can imagine. So what happened for me is accidentally having to fast in that time debulked my tumor enough that it took the pressure off my kidneys for my kidney function to start the tumor was pressing against my ureter. So my kidneys started to function again. It took some tumor burden down to my liver so that my liver started functioning more properly. It relieved that blockage in my bowel so that I could actually start to absorb nutrients and get food into my body. And it helped me resolve the ascites I was having to have to be drained so much. And so I tell you that story so you understand that the implications of something as simple as fasting is amazingly life-saving. And so that was, of course, my first foray into this. And I became an avid intermittent faster from that point on, which I think was really integral. it was still, the other thing that caught my attention is I was also pre-med in school. And I was always shocked when I was like, I didn't understand why no one put together, it was really obvious to me, why no one looked at the imaging. Why no one said, wow, on a PET scan, we're actually looking for glucose uptake in a cancer cell. Why would we not be asking questions as to whether glucose has an impact on cancer? And I would have this conversation, and still do, frankly, millions of times at this point. And people just looked at me like I was from outer space, that was just so far-fetched, and that there was just such a cognitive dissonance, such a disconnect of understanding that like that was one other place that caught my attention. Also, as I got into private practice, it was so clear to me that standard of care alone was failing more than it was helping. And also from our waging war on cancer since 1971, we've barely moved the needle. In fact, we're pretty flatline with regards to our overall survival and our progression-free survival. Unfortunately, we also are having much higher incidence of cancer diagnoses today than ever before. And so I recognize that something more needed to be done. And so that's where I started getting curious, and that's where I started to look beyond what standard of care alone had to offer. And also in my time of being sick, I stumbled across a book or an excerpt of some writings from Dr. Otto Warburg, which caught my attention, that somehow reading that at 20 years old, something in there stuck with me that said, keep digging in here. And then the work of Dr. Mina Bissell, who's famous for her work on the extracellular matrix and this kind of microenvironment. Her work in the 1980s also landed on my lap and really inspired me to look deeper in this area to understand maybe the terrain is more important than the tumor itself. And then folks like Candace Pert and Bruce Lipton, the molecular biologists who started to recognize that even our thoughts impact our inflammatory markers and our immune markers, and started to look in this concept of psychoneuroimmunology, and weaving all of that together painted this picture that I started to even understand that stress and trauma impacted metabolomics, impacted, insulin response, et cetera. So it's just been a really amazing 3 decades of evolution to see what I didn't know back then and what we know now, and what we will know 30 years from now is pretty extraordinary.
Yeah. So that's like an inspiring story from your end also, and it's like your first-hand experience of putting it in practice for yourself and then doing it for patients is really inspiring.
Yeah.
So maybe can you just help us know the role of diet and nutrition in the metabolic approach to cancer, and how, for people who would want to know, how exactly does diet impact cancer metabolism?
Perfect. Well, let's just go really simply here. Think about our mitochondria. They are these beautiful receivers within our cells, right? They're just like hanging out, taking in a lot of information.
Right.
And that information comes in many forms. And first and foremost, that comes from food.
Right.
And it also comes from what we drink and what we breathe and what we're exposed to in our environment, and even we're exposed to in our emotional environment. But those little mitochondria are very mighty, and that they take in a lot of information. And as such, they take in that information and they translate it and send signals out into the body. And so when you know that that's your first sort of entry point into how you can manipulate the environment to create health or disease, it would make sense that you would want to be very thoughtful and determined on what you feed, what information you give those mitochondria. And so our diet is a very foundational way to do that. We all eat, right? We all eat anywhere from 1 to 3 times a day, and sometimes people even more than that. But basically, knowing what it is that you're putting into your body makes a difference. And so it's what we're even learning in the literature is it may not even be, this might throw some people off in this room, but even people work like Dr. Sachin Panda's work in the circadian rhythm biology, we're even finding that when you eat may be just as critical as to what you eat. And so that even like the time of day that you eat may have more impact on your glycemic load or your insulin response than others. So those late night eating patterns, for instance, are truly detrimental to your metabolic health. So looking at the window of when you eat is just as much. And then looking at the process of, are you overfed and undernourished? So maybe you're eating a lot of good stuff, but not the right things for your body, for your single nucleotide polymorphisms, for your personal blueprint of your chemistry and your genetics. Perhaps you don't have access to clean quality food. And so you're taking in a lot of additional chemicals into your body as well, especially endocrine disrupting things like glyphosate, which are very detrimental to our metabolic expression, to our metabolic health, and to our insulin response. It's a well-known endocrine disruptor, so it's going to impact this greatly. And so when we can start to really evaluate what you're eating, when you're eating, the quality you're eating, even the state of mind you're in when you're eating. If you're under stress when you eat, that also lands in your body very differently and impacts things. And so that's kind of this wide broad stroke we're taking over it. But then we can get very nuanced by looking at people's cancer type, stage, what the therapeutic goal is. We can adjust their macros very, very much. So for someone who's maybe a stage 2 early stage breast cancer, maybe they don't have to be in a deep state of ketosis, maybe just a little nutritional ketosis or a little bit of being in ketosis in a cycled state is going to be enough to put enough pressure on the body for the body to do its job. But somebody becomes a little more progressed with the cancer, the tumor bulk gets even bigger, you're going to need bigger guns, right? You're going to need a bigger approach to this. So you might have to dive into a deeper therapeutic state. And you probably had a million people talk about this on your summit, but I let people know that my range of therapeutic nutritional ketosis is from about 0.8 to 2 millimoles of blood ketones, and therapeutic ketosis is above that, roughly kind of 2 to 7, somewhere in that zone. And then you've heard probably Dr. Seyfried talk about the GKI. He likes to, in his environment, to get the GKI under 1, but I also want to assure people here that sometimes that's very difficult and still not attainable by many because of certain pharmaceuticals. Like if you're taking steroids, it's pretty impossible to get a GKI of 1. And so I want people to understand the nuanced needs to address the individual where they are. Just an interesting side note, if this hasn't been brought up, the average person on the planet today, their average GKI, have anybody talked about this on the summit?
No, I don't think so. Anyone would have talked about the entire group.
Right. So this will shock you. So the average glucose to ketone index of the average person living today is between 25 and 30. And what we know, like Dr. Seyfried's work has shown that a GKI under 1 is like a cancer killer, right? That's going to kill it. But what we've actually found is if you actually just work towards, generally, cancer or not, getting your GKI under 5, a GKI under 5 will basically make this summit irrelevant because we wouldn't have to have it, right? Because your kidney disease, your cardiovascular disease, your diabetes, your dementias, your cancers, the obesity, all those things change, right? And so we can caloric restrict, we can time eat, we can adjust our macros, we can really train the patient to understand what's impacting their glycemic response and their insulin response, because what may make me respond poorly may not affect somebody else. Like in my household, my husband, very sensitive to berries, very sensitive, and he can't eat that. So I could eat a pint of them, they don't do anything. We're very different, all of us. So looking at these pieces, diet is something that needs to be nuanced to the individual at the right time, the right dose, the right duration, the right combination with these other therapies. So I'm sorry, I can't give you a very specific, but it's really powerfully nuanced. And it's such a tool that's underserved. And I think for anybody who's in clinical practice, we understand the limitations of our time. That's why we really depend on advocates and nutritionists that are trained in metabolic understanding to help us help our patients be more successful.
Right. That's great. So it's all about personalized nutrition therapy for and integrating it with the entire approach.
Exactly. And another piece, like when we have ketone bodies themselves, we've had plenty of studies now showing that ketone bodies themselves impact every one of the levers of the hallmarks of cancer. And so we don't have a single drug in our pharmacopoeia that can do that. We don't even have a single drug that can target 3 or 4 at the same time, much less 10. And so to have a diet plan or a therapeutic state of ketosis that can literally put pressure and change all 10 hallmarks of cancer, I don't understand why this isn't employed in every single patient we see.
Right, I agree. So maybe, just extending it, can you just, we know that, you have a protocol called the Terran 10. So what are the components or factors that comprise the Terran 10, and why are they significant in understanding the overall health and disease resilience, and how do they differ, or how do you integrate it with conventional approaches to treat cancer?
Lovely. Thank you so much. There's a way that we kind of assess, and I talked about my methodology of test, assess, and address. And part of that is I look at these 10 factors that over my career I have found to be the main drivers, or the main patterns in a cancering process, or really in any chronic illness process. And so these terrain drops in the mitochondrial bucket, if you will, include things like our epigenetics, and which are like our single nucleotide polymorphisms. This is the blueprint that we were born with, that are maybe coming downstream from our family of origin. We can even track back to up to 12 generations before us, and how that may impact our own proclivities and our own, sources of resilience, as well as stress in our bodies. And knowing that information knows us how to leverage the sort of positive aspects of our genome, as well as mitigate or support the more vulnerable, right? So that's one of the drops. The second drop is what this whole conference is about, is the metabolic. So what fuel are those cells receiving, and more specifically, like how is their carbohydrate response? That is a very, very important factor. And so we look at a lot of labs like IGF-1, insulin, hemoglobin A1C, C-peptide, PAI1, et cetera, to really understand. We also use blood, urine, breath ketones where needed. And we also use CGMs to understand how that drop in the bucket is expressing. Number 3, toxins. I've already alluded to that with what's in our food source, but man, it's no longer a matter if you have toxicity, it's how bad is it. Babies today, cord blood shows an average of 200 chemicals just in their cord blood today being born. So this is what we're living in and around. And so we are constantly being exposed to these things, which are very much going to impact our mitochondrial health. And then we look at the microbiome, which just a few years ago, everyone ignored. And yet now it's the soup du jour. Everyone's excited about it and talking about it. And I think people are even more excited about the relationship with our microbiome and our metabolic health. So that's an emerging understanding as well. And then we move into the immune system, which, especially in the cancer space, if the immune system isn't working, you will never achieve cancer remission and maintenance. So that's a big one that we focus on. Inflammation, my goodness, we know how much metabolic derangement really turns up the fire of inflammation. That has to be addressed. And then we look at oxygenation, circulation. This is a big one. Hypoxia is a major contributor to the cancering process. And then the hormone modulation, hormone balance. We're also swimming in a huge swimming pool of exogenous hormones from plasticizers and endocrine disruptors, and all the things. Even taking hormones, like people don't know why they think that's a good idea, but it's really scary when we look at how much we're contributing into the system, and our body doesn't quite know how to interpret all the information coming in. Those mitochondria are even under more duress. And then the final 2 big drops are our circadian rhythm and stress response. So that is very, very critical to just how everything interrelates. And then finally, and what's most often ignored or suppressed, is our mental and emotional health and how it plays a role in all of this. So I help patients, and I help clinicians, and I help advocates understand these terrain 10 buckets, drops in the bucket, and I help them know how to evaluate for and know what treatments best suit each of those expressions of each of those drops in the bucket. And so the terrain is everything. And if one part of that terrain is off, that mitochondria is still under duress. It's still not going to be at its best. So you need to keep turning over every stone to make sure that you are addressing things that could be driving this. So I might have a patient who's like, I've been in ketosis for 6 months and, I'm still sick. My tumor markers are still high. I don't understand what's going on. And then we dig deeper and realize they're up on their computer at 2 a.m, which is going to completely throw off circadian rhythm. The blue light exposure is going to throw off their hormonal pathways. Their insulin goes up in the nighttime if you're still awake during that time. I mean, those are just examples that you can't like exercise away a bad diet, but you also can't diet away a bad lifestyle. So these are the things we're trying to teach the folks, that it's never just one thing, it's all the things.
Right. It's like a full equation which needs to come through to give you the solution for cancer.
Exactly.
Yeah. What are the challenges of misconceptions that you encounter while you are discussing these metabolic approaches to cancer with patients or other healthcare professionals? And maybe you could just take us through some case study which you would have went through, which maybe people can listen into and maybe learn from.
Sure. Well, I mean, first of all, I think there's a huge misconception of just what is ketosis. I think everyone's still stuck on the Atkins phase, that this is just a simply a high bacon diet, and that's all that it is, and you can just go on in life. And in the cancer space, that's a very dangerous approach, because too much protein in the cancer space is also can be very challenging. It can stimulate things like mTOR, AKT, PIK3CA. So these are some of the other metabolic pathways that too much protein can create more gluconeogenesis. I loved your last speaker kind of did that beautiful slide at the end leading to gluconeogenesis. So we do have to be mindful, at least in the cancer space, of not bringing too much of that on board. And so that's one of the things here. But people also think that ketosis is somehow a fad, or a ketogenic diet is a fad. They also think that it's dangerous, and they are confusing that with ketoacidosis. They also think that it's not sustainable. So these are myths that I'm constantly busting. And as someone who's basically been in ketosis since probably off and on for 30 some years, but more focused with the awareness and the actual approach to it with my own diet since 2009, I think it's pretty sustainable. And many of the patients and colleagues I know have done the same. But there's also this misconception that there's no data, right? That there's no information backing this. And yet I just went on this morning just for poos and giggles to see if there was any clinical trials currently enrolling for therapeutic ketogenic diet and cancer right now. 40 in the United States alone are currently enrolling. There are, I'm trying to think of the last count. Miriam Kalamian often posts how many clinical papers have been published, but I think we're now well over 1,000 globally of just specific to keto and cancer. And so when people say there's no data, they're literally just not looking for it. And then finally, a big issue is I think that doctors assume that their patients are not capable of committing to this lifestyle. And to me, that is a travesty. The doctor is blocking the patient before the patient even has a chance. And as someone who has worked with tens of thousands of patients directly and hundreds of thousands of patients indirectly, I will tell you, the doctor who told them this is not sustainable and need to do it probably needs to deal with their own metabolic health issues and has to deal with their own food addiction issues, because they're placing their own belief systems on that patient. And that really stymies the patient. That really disempowers the patient. But I want any patients listening here, you can absolutely do this. We have so many patient stories of the utility of this, ease of this, even into the whole family, not just the patient going through cancer. And I feel like it's important to share the story that really put me on this, even though I kind of had my accidental findings into this space. My very first, I decided I was never going to work with cancer. After this process, when I went to medical school, I was never going to touch cancer with a 10-foot pole. My first week in practice, because I'm also a doctor in renal medicine and acupuncture, my first week of practice, I had a patient come in for pain management. He was referred to me by a local neurologist, and he came in a wheelchair. The parietal lobe of his head was bulging straight out. He was moaning in extreme pain. He could not lift his head. It was so heavy. His wife said that he was in a diaper. He couldn't talk. And what I learned is he had stage 4 Hoof score 4 glioblastoma that was pushing. It had closed off both ventricles of his brain. Now, medically speaking, it's impossible that he even came into my office in a wheelchair. Like, he should be dead. I looked at the imaging results myself. I even had a friend look at him to make sure I wasn't missing anything. Closed. So that means there was no pumping of cerebral spinal fluid. There was nothing was moving in and out. Things were shutting down very quickly. He had unfortunately 3 months before been diagnosed with inoperable GBM, and unfortunately went to a natural healthcare provider who told him he had a parasite. And she basically put him on a carrot juice fast. For 3 months, he lost 52 pounds. And you can imagine the insulin experience here. I still tell this story, and it both enrages me and saddens me of just how bad that would have been bad, even without what we know about metabolic disease and GBMs now. But that was just such malpractice. It's unbelievable. So he came to me for end-of-life care for pain management, because not even the medications were touching the pain. And he was having about 100 seizures a day, and no seizure medication was helping this. So I did acupuncture, and I went back to the literature, because I had known that there was only one thing I knew that could possibly get those seizures under control. And I wasn't looking at this for curative. I was looking at this for quality of life and supporting this man, because those seizures were very traumatic for not only him, but his family. He had 3 young children under the age of 10. And so within 3 days, and his wife, they'd been vegetarians, by the way, for a very long time, even maybe vegan. I can't remember now. It's been so long. Had been like 20 some years in that area. So very carb dense. So that was primarily their whole diet. And then he just came off 3 months of carrot juice. 3 days into a ketogenic diet, his seizures cut in half. Within 2 weeks, he had no more seizures. The parietal lobe came back to normal. His skull looked totally normal. He was able to lift his head. He was able to speak. Within a month, he was not wearing diapers anymore. Within 2 months, he was walking around. This man lived another 18 months past this point where he rolled into my office, and it still makes me very emotional today. He went for a drive that morning with his family up in the mountains. And when he came home that night, they all curled up in bed with him, and he never woke up. So he had an incredible quality of life until the very end. And the crazy thing, his ventricles on repeat imaging had never opened. There was nothing we did but acupuncture for pain management and therapeutic ketosis. That is all we did, and that's all we could do. No one gave him any other options in standard of care. And that was the moment I realized, if I don't employ this with every single patient in some form or fashion in my practice, I am clinically negligent.
That's really, I have goosebumps when I hear this story. Yeah, it's really nice to hear. And in fact, as a part of, I do a lot of research, I was sitting with an oncologist, he said to me that, why isn't this told to us, that, these kind of 65 trials already there, you already have the data in front. So it's all about education, and I think you're doing also a good job, and in terms of the educational programs and resources that you are offering through MTIs to healthcare practitioners and individuals. I think that's going to be very nice, but, if you can just take us through as to what are the upcoming initiatives, projects, and what courses or the educational programs that you offer to these professionals, or maybe cancer patients or any nutritionists, who would want to enroll for this program, and how would they benefit from it?
Oh, thank you for the opportunity to share about this. So at the Metabolic Training Institute of Health, we have an educational program for training clinicians, as well as patient advocates, which are your nurses, your nutritionists, your occupational therapists, like anybody who's got some degree, clinical degree, but not able to order labs and imaging and prescribe. So we've got those 2 sort of tiers. And we're also getting ready to share do-it-yourself, kind of a home-based for caregivers and patients. So that's coming out later this summer. But backing up a little bit, I was in clinical practice until 2015. And by the time I left clinical practice, I had a year-long wait list from people coming from all over the world to my clinic in small town Durango, Colorado. And it was devastating for me to literally watch people dying in the waiting room. I couldn't, the burden that I was carrying to realize I couldn't help everybody led me to bringing in a patient concierge that she helped me start to bring in, which is basically the precursor to our patient advocates, to help these patients on board and get started with things while they're waiting for me. What was so funny is most of those patients, by their visit time came, they were either in remission or maintenance, or were doing really well, feeling better. And I really saw the utility, there's so much that can be done before they're even in front of the doctor. So fast forward from that, I started doing trainings for like doc-to-doc consultations, helping them apply this to their patients. But within a year, my schedule was filled with doctors trying to have me consult with their patients. And I'm like, that's definitely not sustainable. So in 2020, I started my first cohort of clinicians. There were 12 clinicians that I worked with very closely for many years, to say, okay, I'm going to teach you how to fish. I'm going to stop giving you fish. I'm going to teach you how to fish so you can go out and do this. Within 6 months, those doctors had year-long wait lists. Like we realized, oh man, the demand is so huge and there's not enough of us, enough hours in the day to do this. So we are now into our 9th cohort of physicians, over 262 in 36 countries, and now nearly 400 advocates in 36 countries and growing by 2 cohorts a year. This is something we're really proud of. It's under our nonprofit arm. And so any funds coming in go into the overhead of creating and distributing this program, but also goes back into creating patient grants for patients to get care with metabolic therapists, metabolic oncologists, and as well as grants for clinicians and advocates to take the coursework if they can't afford it for whatever reason. And then we also have global pricing so that it makes this more attainable by everybody. We're very excited and proud of how fast that's growing, and the movement is happening in a very big way. And thanks to you guys as well, there was something we also launched October 10th of 2023, which is Metabolic Health Day. This is now a day, and we hope that you all support this endeavor again for years to come. But this is we had our first Metabolic Health Day, 10/10. We had 70 different contributing foundations and organizations and clinicians and researchers come together, and we reached over 6 million people and brought in over $70,000 for research in this arena. That was our very first one. So imagine what the next few years are going to be. And the next on our list of to-dos is we are starting a metabolic health consortium, so that it's not just a metabolic health day, but we can continue to have these conversations in a consortium to really change public policy and medical care systems around the globe in this arena. We also just opened up 2 weeks ago our metabolic testing and novel therapeutic delivery lab in Phoenix, Arizona. So this is where we will be doing research in this space, not just in cancer, but all types of things. But we're also creating novel delivery systems and novel formulations in the metabolic health space. And then we're also actively, pursuing research and pursuing fundraising to help bring in more patient grants so they have access to this care globally.
Yeah, that's really exciting, and we'll be happy to support in whatever form we can. So we look forward to that.
Thank you.
Lastly, Dr. Winters, for the people who are logged in or maybe will see this video, what would be your tips, for somebody to maybe be cancer free or be metabolically healthy? Or as an overall, would you want to give some tips and maybe some pointers for everyone to stay healthy metabolically and cancer free, of course?
I love this question. So really simply, what's free and accessible to all of us is what's in nature and what we can do with our food, right? So one of the things I really encourage, and luckily in this group, you have resources and tools to help you do this safely and effectively, which is where I want all patients to become metabolically flexible, to be able to fast no less than 13 hours every single day, with a little extra push, 16 to 18 hours twice a week. And if you are already doing those things and you're feeling really strong, then if instead of doing 16 to 18 twice a week, maybe a 24-hour once a week. And then once you develop from those and you feel comfortable with that phase, then I want you to start bringing in a 3-day water fast once a month. And seasonally, or at least twice a year, shoot for a 5-day water fast. Now, that may seem extreme, but it's not. I mean, we've co-evolved with fasting therapies through spiritual practice forever. Fasting is long. It's just been around. So if you have the right support system to do this, you can do it very safely and effectively. And talk about an empowering experience, and it's free. And it really helps people understand how much they can do for their own bodies, and to see and feel those shifts is pretty miraculous. And this becomes the ongoing support for them. I also want everybody to start to really get a macronutrient counter. There are tons of free ones online, so you really know what you're eating. Everyone always tells me, I don't eat sugar. And then we look at their diary and we realize they just had 300 grams of carbohydrates at breakfast, right? And we're like, oh, yeah, those that orange juice with your banana on your cornflakes, with your skim milk, not cutting it. So we really want people to understand and really start to understand that if they can get their carbohydrates, if they've got a condition already, getting your carbohydrates under 50 grams a day is going to, across the board, help. If you don't have a condition that you're aware of, keeping them under 100 grams is going to just be very good for kind of supportive. And if you've got a cancering process, there may be times when you need to push those carbs underneath 20 grams a day. So the macronutrient counters are helpful. If you've got the funding to test, the blood ketone monitors are really critical for this, because that in the cancer space is far more necessary than just breath or urine. We really need to understand where we are there. So having a ketone and glucose monitor is very helpful. And then once you get really fat adapted into the groove, this is where a CGM comes in handy, because then you start to understand what's affecting you outside of food. So yes, you can see the food directly from your CGM, but you can also see what happens if you over-exercise, if you under-exercise, if you had a bad night's sleep, if you got in a fight with your boss, if you had an illness, if you were taking a certain medication, you start to see patterns. And so the longevity support and the health support beyond the diet is also about restoring and creating rhythm in your life. So I'm a real avid, passionate believer in watching the sunrise and sunset wherever I am. Right? I get up and I meditate in the morning in front of the sunrise. That's just where I have my balcony that sits out that way. Again, free to everybody. When I'm traveling, I try very hard to adjust to where I am and figure out where east and west is so that I can get out and maintain that. So those are some samples. I also make sure I'm taking walks, moving my body every single day. And maybe every once in a while doing some high intensity interval trainings or saunas. Those are some other things that are great. So sweating. So, lots of these different tools that you can bring on board that are just about helping take out the garbage, helping take the burden off what those mitochondria are taking in, helping restore the rhythm. And by doing so, you're really addressing all 10 of the hallmarks, all 10 of the terrain drops in the bucket, and giving yourself the best chance of resilience and prevention.
Thanks. That's really great. And I think if every one of us puts these insights in, all of us would be out of our jobs. And
absolutely, let's make that the case.
Yeah, let's make that the case. Yeah. So thank you so much. And maybe I'll just call up Shashi and Anup to just give on their closing remarks.
Wonderful.
Yeah.
Dr. Nasha, welcome and thank you for coming again in the second Metabolic Health Conference. We are so happy to have you, and you have come in the right time, in the right conference, because sometime back, I don't know if Harshal told you that one of the largest group of hospitals in the Apollo group also declared that we are the cancer capital now of the world. So it's really going up, and your course, Metabolic Terrain Advocate course, is again very beautiful, and I have joined, of course, with your regional wise or geo pricing, which really made very attractive year-long program, and I'm sure I'm going to learn a lot from this. And we'll keep supporting your Metabolic Day also, the 10-10 again. So when it comes again next time, we will make some video or something, some activity, and send it over to you. So thank you very much, Dr. Nasha, and I will see you again. Namaste from India.
Namaste. Thank you all.
Thank you.